1 hour session in a single appointment with minimal invasive prefabricated, periodontal prefabricated composite veneers. Now, periodontal patients, like the patient that you see in the picture, are not uncommon in my practice. In my aesthetic practice in Italy, I see a lot of periodontal patients because I work with some of the finest periodontologists in the country and the very best experts in the field. And of course, it's always a pleasure and honor to work with the experts. It's always a learning opportunity, and I couldn't ask for more. But when you work with the expert, the problem is that the experts, they tend to see the difficult patients, patients that other dentists don't like to treat. So they complete the periodontal treatment and then they send the difficult patients to me for aesthetic restoration. And when I'm saying difficult patients, this is what I mean. These are some of the patients that were referred to me by my dear friend periodontologist for aesthetic restoration. This was a lady from Naples. This was a young guy from Milan. This was another guy from south of Italy. This was a guy from Rome. Uh, this was a guy from Sardinia, beautiful island off the coast of Italy, between Italy and France. And this was a lady in her early 40s from Milan. So these are the difficult cases. And most of the time, these patients arrive to my office with a small note from the periodontologist saying, "Dear Claudio, please do your best to restore the patient to natural smile appearance." And I will do my best, but hey, these are difficult cases. Periodontal patients are probably the most difficult patients for aesthetic restoration because there are several challenges involved in aesthetic treatment of a periodontal patient. Challenge number one, periodontal disease is frequently associated with dental and gingival aesthetic alteration. So it's both dental and gingival. You know how we make a distinction between white aesthetics and pink aesthetics. And white aesthetics is aesthetics pertaining to teeth, while pink aesthetics is aesthetics pertaining the surrounding soft tissues, including the interproximal papilla, gingival tissue. Now, periodontal patients, they have both white aesthetics and pink aesthetics issues because as periodontal disease progresses and bone and attachment get lost, teeth start drifting apart and in spaces opening between the teeth, the gingival tissue recedes and the root of the tooth gets exposed. And also the interproximal tissue shrinks and black triangles form in the gingival embrasure. And these are some of the dental and gingival alteration associated with periodontal disease. And most of these alterations persist even after complete healing from the disease with major aesthetic and functional implications for the patient. Now, there was a time when we didn't see this type of periodontal aesthetic problems because most of the periodontal teeth were lost before we could see them. But today, thanks to earlier diagnosis and better periodontal treatment, many periodontal patients can retain their natural teeth for possibly a lifetime, even after significant bone and attachment loss. And this is a very good thing. But now we need to treat these patients. We need a technique to restore this smile to natural and healthy appearance. And you know what? It would better be a minimal invasive technique because most of these patients went through long and complicated and expensive and sometimes painful periodontal treatment because they want to retain their natural teeth. So now that their natural teeth have been saved, you bet they don't like to have them aggressively prepared for crowns and maybe root canals. So this is challenge number one. Then we have challenge number two. Challenge number two is we are dealing with delicate soft tissue. So we need extra care in any clinical procedure, tooth preparation, impression taking, soft tissue attraction, management of the temporary restoration, because we don't want to traumatize the soft tissue and trigger more soft tissue alterations, especially in patients with thin gingival biotype. And then we have challenge number three. Challenge number three is the persistent risk of soft tissue migration forever. In periodontal patients, the dynamic equilibrium between bacterial challenge and host response, it's always susceptible to break down and produce more soft tissue alteration in the future. Periodontal patients are unlikely to be stable forever, especially a severe periodontal patient with high risk profile and a strong genetic component. Now, minor soft tissue alteration over the course of the year, it's probably no big deal if you restore the patient with direct composite, because you can always add a little bit more composite and compensate for the soft tissue alteration. However, if you restore the patient with indirect ceramics, now you have a problem, because indirect ceramic doesn't allow intraoral repair. So even minor soft tissue alteration in the highly visible upper anterior area could lead to aesthetic failure of your restorations because of exposed margins, open space in between the teeth, black triangle formation, with consequent need to prematurely replace the restoration. But when you do so, now you have to reprep, take new impression, new temporary. So it's extra stress for the soft tissue and even more higher risk of soft tissue alteration. So it's like a vicious circle. So these are the challenges associated with aesthetic treatment of periodontal patients. And challenge number one, there is really not that much that you can do there to control the risk. The only thing that you can do is to cross your fingers and hope that the periodontologist doesn't send you the difficult cases. Sometimes it works, sometimes it doesn't work. However, challenge number two and challenge number three, you will see how you can do something here to reduce the risk. And actually, the technique that I'm going to present you today, the periodontal prefabricated composite veneer technique, is very well indicated for treatment of periodontal patients because reduce the risk associated with dealing with soft tissue, dealing with delicate soft tissue, and the risk of soft tissue migration over the years. So these are the challenges. So it's difficult. It's difficult, but it's not impossible. This patient, they can be restored to natural and healthy smile appearance. And some of the things that I've learned from aesthetic treatment of periodontal patients are this. Lesson number one, aesthetic restoration has major social and psychological implications for the periodontal patient, can really make a difference in their quality of life. The other thing that I've learned is this: aesthetic restoration has a positive impact on patients' drive to maintain optimal oral health. Now, as all we know that optimal oral health is critical for long-term prognosis of periodontal patients. Um, However, high levels of oral hygiene motivation are difficult to pursue when the periodontal disease has compromised the appearance of the smile. What I'm saying is that this periodontal patient have little motivation to maintain in optimal condition a smile that they are not happy with, they are not comfortable with. We know that a strong correlation exists between physical beauty and health behavior. We know that physically attractive people tend to make more effort to maintain or even enhance their beauty appearance with a healthier lifestyle, like better food, more physical exercise. And the same happens for dental appearance. People with attractive smile tend to make more effort to maintain their beautiful teeth than people with an attractive smile. This was a research published on the American Journal of Orthodontics and Dentofacial Orthopedics. And in this project, they compare oral health in people with attractive smile and people with unattractive smile. And they found significant difference in oral health behavior between the two groups. Uh, People with attractive smile, that's the highest static here in the picture, brush more, they floss more, and they go more often to the dentist for checkup. As a result, because they have a more beautiful smile and they want to keep it, they have less gum bleeding, less caries, and less plaque accumulation. So this is one of the reasons why aesthetic treatment of periodontal patients is very important, because it motivates the patient to maintain their smile in optimal oral health condition. So this is another lesson that I've learned from treating periodontal patients, and that is this is successful periodontal treatment is not completed until the static sequelae of the disease have been treated and the smile restored to natural and healthy appearance. As I say, uh, restoring this patient is difficult, but it's not impossible. This was a case of a periodontal patient restored with a combination of orthodontic treatment and ceramic veneers in this case. This was another case of a young lady in her early 40s that was restored with a multidisciplinary treatment involving periodontal connective tissue graft, orthodontic treatment, and a combination of ceramic veneer and composite veneer this time. So this was a successful aesthetic treatment, but it was long and complicated and expensive treatment. Now, it doesn't have to be always like that. And today I will show you how you can produce major improvement in the smile of your periodontal patient in a single appointment using periodontal prefabricated composite veneers. Periodontal prefabricated composite veneer is a variation of the standard prefabricated composite veneer technique introduced in 2010 for anterior restorations. And this is the paper on the European Journal of Aesthetic Dentistry, summer 2011. This was the paper that introduced the new prefabricated composite veneer technique. And this paper was signed by Didier Dietschy and Alessandro Davigus, who's going to be one of the speakers tomorrow, I believe, at this time. So this technique is based on a new concept of pre-shaped and pre-polished composite veneers. They are available in different shapes and size for direct bonding to the deserving tooth using a complementary shade match composite resin. So with this technique, if you have a tooth that needs a veneer, like this upper lateral incisor, because there is no way to achieve optimal aesthetics simply by redoing this class 3 mesial and distal composite. Now, what you do is you prepare the tooth for minimal invasive veneer preparation. Then you select the prefabricated composite veneer of the proper shape and size. This was an upper lateral incisor, size small. Then you load it with composite and light cure it in position. And here you have, this is a prefabricated composite veneer on, let me go back, a prefabricated composite veneer on the upper lateral incisor. So basically, this technique bridged the gap between a conventional direct veneer and a conventional indirect veneer technique. From the direct technique, you have the convenience of a single appointment, like a direct composite veneer that you do in a single visit with reduced chair time, reduced clinical steps, and reduced possible complications. And from the indirect veneer technique, you have the beauty of a pre-shaped and pre-polished restoration. Like the ceramic veneer that the laboratory fabricates for you, prefabricated composite veneers have ideal shape, a proper size, accurate anatomy, glossy surface. So very nice aesthetics. You don't have to do any shaping and polishing here because it was made for you. And these are composite veneer, but this is pre-cure composite outside the mouth. So you don't have the limitation of conventional intraoral composite curing and composite shrinkage. So this technique was introduced in 2010. And now, 10 years later, there are basically two main players in the prefabricated composite veneer arena. One is a Companier by Coltine from Switzerland, and the other one is Edelweiss Veneer from Edelweiss Dentistry from Austria. Now, both Companier and Edelweiss Veneer share the same concept of pre-shape and pre-polished composite veneer, and also share the same clinical procedure. It's a very similar technique. However, it's a different material and different fabrication technology. Companier from Coltine are fabricated with Coltine Universal Composite, Brilliant, that is light cure in a shape of veneer. Edelweiss veneers are fabricated with Edelweiss nanohybrid composite that is light cured in a shape of veneer with the addition of heat and pressure, and then the restoration is laser sinter. So it's a more advanced fabrication technology. And the fabrication technology of Edelweiss veneers starts from a small ingot of homogeneous nanofill composite. And first the ingot is heated at 300 degrees. And when composite reaches temperature, it becomes very fluid. It's almost like water. And now it's pressed into the veneer mold under 100 bars pressure and finally cured. And it's cured under vacuum. So there is no oxygen to interfere with the composite setting. And when composite is cured, the veneer is laser sinter. There is a sintering laser that goes through the thickness of the veneer and bounces back. So it's actually double sintering. And the sintering laser produces very high temperature. And the high temperature evaporates the resin and melts the filler, producing a highly aesthetic glazed surface. So the glossy surface that you see on top of Edelweiss veneer, that's laser sintering. So Edelweiss veneers are fabricated with a combination of heat and pressure curing. As a matter of fact, it's a lot of heat, a lot of pressure, is 300 degrees and 100 bars pressure, and then they are laser sintered. And this technology produced a restoration with remarkable improved mechanical and physical properties compared to conventional composite restoration, especially direct composite, and a highly aesthetic laser sinter glaze surface. So Edelweiss veneers are now available also in a new version called Edelweiss long veneers for treatment of periodontal patients. Edelweiss long veneer, they share the same material and the same fabrication technology as the standard Edelweiss long veneers, but it's a different shape and size. The main difference is the size. Edelweiss long veneer feature a 15% extra length of the clinical crown to fit elongated periodontal teeth with gingival recessions. The width to length ratio of Edelweiss long veneer is 72%. Now, you know that ideal width to length ratio for upper anterior teeth falls in a range between 72 and 85%. So if your central incisor is 10 centimeters long, the width should be anywhere between 7.2 and 8.5 centimeters. Now, the width to length ratio of Edelweiss long veneer was set at the lower limit of this range in order to have the longest possible clinical crown to restore even the large gingival recession, but a tooth that is still within natural tooth proportion, so it doesn't look too long. So size is different, number one. The other different is the shape. The shape of Edelweiss veneer was designed to fit periodontal teeth with open space in the gingival embrasure, black triangles. So the contact point was repositioned toward the gingival third to reduce the distance between the contact point and the interproximal bone crest and facilitate the papilla to fill the gingival embrasure with no black triangles. And then the other difference is the wraparound shape. Edelweiss long veneer have more wraparound shape than standard veneers, with more extension in the interproximal space, including the gingival embrasure. So this is how they are made. Now, Edelweiss long veneers were introduced in 2019, last year. So the case that I'm going to show you now was one of the very first periodontal patients that I've treated with this technique. And I will show you the case, and I will also show you the 12-month recall just completed this summer, just after the lockdown. So the patient was a 62-year-old male referred by the periodontist for aesthetic restoration of the upper front teeth. The patient was currently in a periodontal maintenance program after completing a full upper and lower implant supported restoration, both upper and lower arch. And radiological examination revealed severe horizontal bone loss, and periodontal charting revealed no pocket depth greater than 3 millimeters, no tooth mobility, and no sign of gingival inflammation. So patient came to the office with aesthetic complaint. Primary aesthetic complaint was the large gingival recession and large black triangles. And this is really not uncommon in periodontal patients, especially black triangles. It's a very frequent complaint in periodontal patients associated with uh, food entrapment, speech impairment, and of course, compromised aesthetics, especially in patients with high lip line. So black triangles are always on top of the list of aesthetic complaints in periodontal patients, especially when they are on the upper arch and close to the midline. Secondary aesthetic complaint was the vertical crease line, brown crease line, and also some medium to large composite restorations that are not properly integrated. And patient was also complaining of severe sensitivity, dentin sensitivity, despite treatment with nerve desensitizing agent and also dentin tubal blockers. Teeth are still very, very sensitive. So basically, this was a patient with large gingival recession and large black triangles. And gingival recession are class 4 gingival recession according to Miller classification. As you know, several classifications are available for gingival recession, but the Miller classification from 1985 is still the most popular classification to classify gingival recession and also to predict the possible outcome of surgical treatment for root coverage. And you know how Miller class 1 and Miller class 2 are very well indicated for surgical treatment, and complete root coverage can be anticipated. Miller class 3, they are still indicated for surgical treatment, but only partial root coverage can be anticipated. Miller class 4 with severe bone loss and severe soft tissue loss are not indicated for surgical treatment because no root coverage can be anticipated. Patient also has large black triangles. These are class 3 black triangles according to Nordland and Terno classification. Class 3 is when the tip of the papilla is apical to the facial CJ. However, even more important than this distance is this other distance, the distance between the contact point and the interproximal bone crest, because this is the main predicting factor for the presence of black triangles. Other factors, there are other significant factors for black triangles, like triangular tooth shape, divergent root, gingival biotype. But the distance between the contact point and the interproximal bone crest is the main predicting factor. And we know from studies made by Tarnow in the human population in the 90s that when this distance is 5 millimeters or less, the papilla fills the gingival embrasure almost 100% of the time, and you have no black triangles. However, when the distance between the contact point and the bone crest is 5 millimeters or more, then you have a black triangle. And the longer the distance, the larger the black triangle. Now, for this patient, the distance was 10 millimeters or more, and this is why you have these large black triangles. And so the new restoration, the contact point will have to be relocated as close as possible to the 5 millimeter limits in order to close the black triangles. So after collecting all the clinical and radiological examination, I met the patient for a second appointment and we discussed treatment options. Now, surgical treatment is frequently recommended for a gingival recession and a coronal advance flap with subepithelial connective tissue graft. It's considered the gold standard because of the highly predictable and durable results. However, in case of Miller class 4, like this patient, no surgical treatment is indicated because no root coverage can be anticipated with this significant bone loss and soft tissue loss. So we discussed the alternative restorative treatment option and with pros and cons. Now, one treatment option was direct composite. With direct composite, the good thing is that composite allows to restore the gingival recession in a single appointment with a very minimal invasive and predictable technique. But the limitation for direct composite is the large size of the gingival recession for this patient, because we know from all the clinical studies how large cervical composites have much higher failure rate than small cervical composites. And another limitation was the size of the black triangles, because it's very difficult with freehand composite to produce a restoration with proper emergence profile, ideal contact point position, and optimally polished composite in the interproximal area. So direct composite restoration was a possible option, but with significant limitations because of the size of the recession and the size of the black triangles. And this limitation applied to both uh, tooth color composite and pink composite for restoration of gingival recession. So we consider another treatment option with indirect ceramic, conventional treatment option with ceramic. And ceramics, the good thing, you can produce highly static and durable results. But the limitation is that indirect ceramic, it's a very invasive technique for periodontal teeth with large gingival recession, large black triangles because of the triangular tooth shape. Because of the triangular tooth shape, in order to bypass the undercuts, it takes a very invasive preparation with significant sacrifice of healthy tooth structure and probably elective root canals on some of these teeth. Another limitation for indirect ceramic was the high risk, was the extra stress for this delicate periodontal tissue because of the multiple clinical steps. So also indirect ceramic was an option, but with significant functional and biological limitation in this case. So after considering all the treatment options, the final decision was to restore the teeth from canine to canine using periodontal prefabricated composite veneers. And the decisional criteria for periodontal prefabricated composite veneers were number one, minimal invasive preparation. Prefabricated composite veneers are super thin composite shell, thinner than a ceramic veneer. So it requires minimal sacrifice of healthy tooth structure. And on top of that, this is a direct technique. So you don't have to remove the undercuts. You don't care about to bypass the triangular tooth shape. You can restore the space in the gingival embrasure with no tooth preparation. Another consideration was the minimal stress for the soft tissue, because this is a single appointment procedure. There is no soft tissue attraction, there is no impression, there is no temporaries. So there is really minimal stress for the soft tissue and minimal risk of triggering additional soft tissue alteration. Another consideration here was the possible intraoral repair. Prefabricated composite veneer allow intraoral repair with direct composite. So if this soft tissue should eventually further migrate in the following years, it can be compensated with direct composite and thereby expanding the lifespan of the restoration. And intraoral repair is a very critical factor for successful restoration in periodontal patients, especially restoration in the highly visible anterior area, because intraoral repair allows minimal invasive intervention as opposed as replacement of the restoration with major uh, biological and financial benefits for the patient. And in the recent years, the advancement in composite to composite adhesive technology have favored a significant increase in clinical practice to perform intraoral composite repair with very good medium to long-term results. Final criteria was the cost-effective technique. When risk factors indicate a possible progression of the periodontal disease, and when the long-term prognosis of the periodontal teeth is unknown, this is a very reasonable alternative to more expensive and more invasive indirect ceramics. And with prefabricated composite veneer, I can produce highly aesthetic restoration with ideal size, nice anatomy, glossy surface, but without the cost involved in an indirect technique. So once the patient has approved the treatment with periodontal prefabricated composite veneer, the procedure starts with selecting the color of the composite to cement the veneer. And this is a very important step because the color of the composite is what determines the color of the veneer. Because Edelweiss veneers are fabricated with a semi-translucent enamel composite shade. So they have no color. You can actually read through the veneer. So the color of the veneer is determined by the color of the composite. If you cement the veneer with A1, your veneer will be A1. If you cement the veneer with A3, your veneer will be A3. And inside the Edelweiss toolbox, you have everything you need for the procedure, including Edelweiss Nano Hybrid Composite in several dentin and enamel colors. You have the 80, this is the bleaching shade. It's whiter and a little bit more opaque than A1 for patients who want to have very white teeth. Then you have dentin A1, A2, A3, A3.5, and enamel shade. And inside the kit, you also have these are the effect shades. These are the white and blue tint that you can use inside the veneer if you want to add more color characterization. And these are BIS-GMA based, so just paint it inside the veneer and light cure where you want to see the effect. And you also have the shade guide. This is a custom shade guide. It's made with the actual Edelweiss composite that you use to cement the veneer. And so what you see is what you get. And here I see that tooth color is A3. So to cement these veneers, I'm going to use A3 in the middle third of the veneer. I'm going to use A3.5 in the gingival third. And I'm going to use enamel shade in the incisal third. I want to use more colors because I want to increase as much as possible color gradation from gingival to incisal. Higher chroma in the gingival, more translucency in the incisal, because this reduces the visual length of the veneer compared to a monochromatic restoration. So this is why I'm going to use more colors here. So I select the color first, then I select the size. Edelweiss long veneers are available in three sizes: small, medium, and large. And to select the size, the system includes a sizing guide. It's a plastic tray with the outline of the veneers in the different size. And you just bend it on the teeth and see which size fits your teeth. And for this patient was size M. And as you see, I always double check the veneer, try the veneer directly on the tooth. And if for some reasons I don't like this size or I want to try a different size, I try another size, and the size of the veneers that I'm not going to use it, I can autoclave it and use it for another patient. You can autoclave Edelweiss veneers. But at the size of Edelweiss veneer is based on average tooth dimension in the human population. So you will see that most of the time, one of these small, medium, or large veneer will do for you. But if you want to have a different size, a custom size, of course you can do it. For example, if you want to have somewhere in between small and medium veneer, you take the medium veneer and adjust it a little bit on the mesial and distal to make it more narrow. And don't forget that this is not ceramic. This is composite and feels like composite. It cuts like composite, and you are free to make chair side alteration like a conventional composite restoration. And you can use any composite instrument you like, disc, rubber instrument. You can even use diamond burr because this is a very strong composite. You can use diamonds with no fear of accidental breakage. So you can change the size if you like, and you can also change the shape. Edelweiss veneers are fabricated in a universal um,
So Tommaso,
shape.
I have shared your number. No, please speak to me because I'm in the console now and doing this phone call.
I have a voice underneath. Sorry. Okay, sorry. Um, so they're fabricated in a universal shape. This shape includes primary tooth shape, square, triangular, and round. So it means that it's a shape that is made that you can alter the outline and make it into a rounder or more taper veneer if you like. So once you have now you have the size, you have the color, and you're ready to prepare tooth. Tooth preparation for Edelweiss veneer is just like a standard veneer preparation. So it's minimal invasive reduction of buccal enamel. But this is even more minimal invasive than ceramic veneers because these veneers are thinner than a ceramic veneer because you don't need to reduce the incisal edge, no need for incisal overlap because you don't need to open the interproximal contact and because you can keep the margin supragingival like you see here in the picture. You can keep the margin of Edelweiss veneer supragingival because the margin of Edelweiss veneers are invisible. You don't see where the veneer ends and where the tooth starts. This is because the veneer is very, very thin in the gingival third, 0.3 millimeter, and it's made with highly translucent enamel. So this combination produce optimal contact lens effect and invisible margin. And if your margins are not visible, why you should move the margins under the gum level? So you can keep the margins supragingival, and this makes everything a lot easier. Preparation is easier, finishing is easier, maintenance for the patient is easier, and not to mention how supragingival margins produce optimal soft tissue response. And this is another reason why this technique is very well indicated for treatment of periodontal patients. So this is a very minimal invasive preparation, and it's also a very quick preparation because you don't have much to prepare, and because you don't have to produce, the perfect textbook preparation with super smooth surface, round internal angle, sharp gingival margin, like when you have to take an impression because you don't have to take impression here. So you can do your prep very quick and shouldn't take you more than half a minute. And then now next step is bonding, and on the tooth this is a very standard procedure. You can use the same bonding system that you use for your direct composite. I use etch a rinse. I am an etch a rinse guy, but if you like to use self fetching, you can use self fetching. On the inside of Edelweiss veneer, you use this is called veneer bond. It's a primer for Edelweiss veneer. You apply with a micro brush and light cure for 10 seconds, and now the veneer is ready for bonding. So you don't need to sandblast the veneer, you don't need to etch the veneer, you don't need to use silane, but you have to use veneer bond. If you don't use veneer bond or you use a different primer, the luting composite will not stick to the inside of Edelweiss veneers. So now the veneers are ready for loading with composite. But first, this is a case where I'm going to use the effect shades because I want to have more colors in my veneers. So I'm gonna use Effect Blue and Effect Eyes. Effect Eyes, it's a white tint, and I use it to create white spots, white crease line, and sorry, let's go one step forward. White spot, white crease line, and also a thin line on the incisal edge to increase the halo effect. And then I'm going to use also Effect Blue to increase the gray blue translucency in the incisal third. Now, Effect Blue is a very special material. This is not a blue tint. A blue tint is an opaque material with some blue stain. Effect Blue is an opalescent composite. Because of its chemical composition has the same optical behavior as opalescent enamel. It means that it reflects the short light waves, the blue waves, and let the long light wave pass through the yellow or orange waves. So it has a light dynamic optical behavior similar to natural enamel. And this produces a very soft and natural effect, more natural than when you use an opaque material. And it's also very easy to modulate. If you want to have a more intense effect, you add a thicker layer. If you want to have a more subtle, soft effect, use a thinner layer. So now after using the effect blue and effect eyes, again, this is not the regular procedure, but for this teeth, I want to have a more polychromatic restoration with color gradation from gingival to incisal, because this makes the tooth looking less long than a monochromatic restoration. And now I load the veneer with composite shades, and then I push it in position on the tooth. And when the veneer cups, sorry, when the veneer contacts the adjacent teeth, now I know that the veneer is in position. And when I push the veneer on the tooth, some extra composite will flow from the margin. And now I always spend a little bit more time at this stage, and I remove the extra composite nice and clean before curing, because this makes the finishing much faster and easier later. And I like to use this thin spatula like this. This is a compost sculpt by Hugh Freedy, but also other similar instruments are available. But I like to use a thin spatula because it cuts the extra composite in a single piece, like a surgical blade. And the other reason is because this thin spatula reaches well in the interproximal spaces, and you achieve optimal adaptation there, where it's always difficult to finish with hand instruments. And please note, the color gradation and the halo effect and the translucency inside of the veneer that I made with using different composite and effect blue shades. Very, very nice aesthetic outcome, I think. And so now the veneer is in position. I light cure it for 40 seconds, and then final step is finishing with composite instrument. Again, this is composite. It feels like composite, and you can finish with whatever composite instrument you like. I like to use Softflex disc and paper strips in the interproximal spaces. And if you have been good at removing the extra composite before curing, this is going to be very, very quick. Also, because you have to finish only the margins. You don't have to do any finishing and polishing on the buccal surface, because these veneers were already finished and polished for you with proper shape, accurate anatomy, concavities, convexities, and super glossy laser sinter surface. So you don't have to do anything there. So this was the procedure, and I used the same procedure to cement all the 6 veneers. And once all the veneers were bonded, I checked occlusion, and then I dismissed the patient, and the patient came back 4 weeks later for a post-op evaluation. And this was the patient at the post-op evaluation at 4 weeks. And at 4 weeks, functional, biological, and aesthetic evaluation were performed, and they were all satisfactory. The veneer integrate very well with the pre-existing ceramic restorations, both upper and lower. And as you know, this is a very good result, because it's very difficult to mix different restorative material in the anterior area and have uniform optical behavior. The soft tissue show optimal biologic integration with no sign of stress for the soft tissue. But again, this was a single appointment procedure with no soft tissue retraction, no impression, no temporary. You just cannot be any kind, and supragingival margin. So you just cannot be any kinder than this for the delicate soft tissue of the periodontal patient. And the patient also report that sensitivity was disappeared after placing the veneer. So the patient was happy. He went back home. He continued his periodontal maintenance program, and then he came back after 12 months for a new reevaluation. This was the recall at 12 months this summer with new X-rays and new periodontal probing. At the 12 month, the veneer looked very good. There is no marginal staining, no superficial alterations. Superficial luster is very similar to the adjacent ceramic restoration. And the soft tissues show optimal biologic integration. There is still a little bit of black triangles, but considering this, the big size of the black triangles that where we start from, this is a pretty good aesthetic result, and it's possible that in the following years it will get even better. So this was a successful aesthetic and functional restoration of a periodontal patient using periodontal prefabricated composite veneers and with minimal invasive tooth preparation and minimal stress for the soft tissue. And if this soft tissue should further migrate in the following years, and it's possible in a high risk profile patient like this, it's no big deal. I can always compensate a minor alteration with direct composite with no need to replace the restoration. So the question now is, could a patient like this with gingival recession and large black triangles be restored with a different restorative technique? And the answer is, of course, yes. Other restorative techniques are available, both direct or indirect technique. Each technique has its pros and cons, but the periodontal prefabricated composite veneer technique is not intended to replace traditional restorative technique, but to introduce an additional treatment options and to implement a choice for aesthetic restoration of periodontal patients. And as the number of periodontal patients that needs to be restored to natural and healthy smile appearance increases, and increases because of the advancement in periodontal therapy, because life expectancy is rising, because people are retaining their natural teeth longer, now the need for restorative technique increases.
You're muted. You're muted. You're muted, Claudio. Kindly unmute yourself.
Claudio, unmute yourself.
Unmute, please.
Oh,
Okay,
yeah.
here we go. So let's start from this. So I'll go back. Maybe I repeat something. Sorry, but I don't know where I stopped, where I went unmute. So I was saying this is not intended to replace your conventional restorative technique, but to introduce an additional treatment option for aesthetic restoration of periodontal patients. And as the number of periodontal patients increases because of the advancement in periodontal therapy, the life expectancy is rising, people are retaining their natural teeth longer. Now the dentist is facing with a larger variety of aesthetic and functional needs to be addressed in the restorative phase of the treatment. So in this phase, to have more options is beneficial because the larger the number of options, the higher the likelihood for the dentist to find the treatment that best fits each patient needs, expectation, and financial possibilities. So, and I would like to remind you how there was a time, and it was not long ago, when a periodontal patient like this would have been treated with crown, full coverage crown with root canals. Whereas today, the advancement in periodontal therapy and the clinical success of adhesive dentistry have changed the way dentists treat patients like this with less invasive, less complicated treatment options and more treatment options. And of course, to have more treatment option, it's for the dentist, it's more complicated than single options because all the clinical implication and all the different perspective, and also because as dentists we are usually better trained at taking impression than taking decision. However, from the patient point of view, to have more option is good because more option is better care. And this is true for every dental patient, but even more so for periodontal patients who are sometimes challenging to restore. So this was my final consideration for this presentation about treatment of aesthetic treatment of periodontal patient, and this is how I would like to thank you for your attention. Okay.
Dr. Claudio, can you please
Yes.
stop your share screen, please?
Yes.
Yeah.
Let me go
And just
here.
be with us.
Okay.
Okay.
Uh,
So please accept our sincere appreciation for this outstanding presentation. It was
thank
very
you.
interesting to hear your experience on aesthetic treatment for periodontal patients. And of course, it adds to a new dimension for restorative aesthetics for periodontal patients. So thank you so much for sharing your thoughts and experiences. On behalf of the whole board of IACD, I express that. And we have a couple of questions. In fact, we have more than 10 questions, but since considering the time, I would go in for a couple of questions. The first question, what a participant wants to know, is there a bonding issue? Because you're actually bonding the cementum. Because you're not going to get predictable bonds on cementum as you get on enamel and dentine. So could that be an issue with this technique?
No, this is one of the good things with composite veneers compared to ceramic veneer. Ceramic veneer, if you have no enamel, it will debond. Composite veneer, it doesn't debond, even if you are on dentin. And this has to do with the mechanical behavior, with the flexibility of the composite. Now, I'm not going to get into that, but the point is composite ceramic veneer, they have a debonding issue. Composite veneer, they bond much better. We all know, I mean, we have been doing direct composite veneers for many, many years, and eventually they chip, they stain, but they do not debond.
Okay, okay. I think that answers the question. The second question is there any special precaution we need to consider for sensitivity as an issue in such exposed root dentine?
No, actually not. Most of the time, my experience, when you cover the exposed dentin, sensitivity will go away. Uh, in some patient 100%, in some patient maybe 50%, but it will definitely improve the sensitivity.
Okay, finally, just one question. What is your experience on longevity of these periodontal veneers?
Periodontal veneers I have been using for 1 year, so I cannot answer for that. But the standard Edelweiss veneers, I have been using it for 10 years now, and my experience with longevity is that it's much longer than a conventional composite veneers because of the fabrication technology. The material is totally different, so it's much longer than conventional composite.
Thank you so much.
Deepak, may I just about make a comment, please?
Yeah.
Thank you. Claudio, thank you for your presentation. I would like to sort of give a clarification, if I may, that when we speak about gingival or periodontal epithesis, we normally speak about a prosthesis, a flexible material, which is worn, also called as party gums, essentially to block out the black triangles. What I see through your procedure is a wonderful medium by which you're essentially utilizing the tooth surface, expanding the tooth surface through veneers, and trying to block out the black triangles without touching the pink. So is there in future a possibility of combining the gingival epithesis of party gums and this technique so as to achieve more predictability and better aesthetics?
It makes a lot of sense to me. Again, uh, my experience with this, with treating this patient, is that the more the options, the better it is. I mean, because they are difficult. So you cannot manage this patient with just, ceramic or composite. You need more option, and this is another options that could benefit many patients. Yes, I think so.
Thank you, Claudio. Thank you.
So Claudio, because of your presentation, there are a lot of questions and inquiries on from where can we get these veneers. So I've been using this since past 3 years. So just for all the information for all the participants, you can please log into networking launch. Dr. Nikhil Bahuguna would be there to answer your questions on the availability. You could also check on Dental Matters group on Facebook. So thank you so much, Dr. Claudio. Now, on behalf of the Indian Academy of Aesthetic and Cosmetic Dentistry, please accept a token of appreciation from us. And trust me, this would be mailed to you in 24 hours. Thank you so
Great.
much, Claudio, for having you. Thank you.
Thank you to everybody. Goodbye.